Yes, we are live, sir. Ashmita?
Yeah, I'll start.
Yeah.
Good evening, everyone. Welcome to the White Army. Today, we are blessed to have with us Dr. Rajashekhar sir for a very, very important discussion on approach to acid-base disorders in the ABG analysis. Sir has completed his MBBS from KIMS Hubli, MD Internal Medicine from UCMS Delhi, and he has a fellowship in Diabetology from CMC Vellore. A very hearty welcome to you, sir.
Thank you.
Sir, kindly begin the session.
Okay, thank you all. Good evening. So, this on request from many students. So, I have decided to take this topic, that is approach to acid-base disorders. We'll be dealing with this approach in two parts. I could not cover entire session in single part because of the time issue. So today we will be covering the basics of this approach to acid-base disorders and metabolic acidosis. So in the part 2, we will consider metabolic alkalosis and the respiratory disturbances in the next class. Okay. So this is very, very important. Many of the UGs consider it as a difficult, so they usually omit studying ABG, and many of the PGs understand it in half knowledge and they could not apply in their clinical practice. If you go to any exam nowadays, be it an UG exam or a PG exam, the one or the other ABG question is must. I think in last year NEET SS in nephrology, we had more than 10 to 12 questions related to the straightforward questions on acid-base disorder, where the case scenario was given and we were asked to guess what the acid-base disorders the patient was having. So the questions are like must coming in the coming years also. Like every exam is expected to have at least a single question on the acid-base disorders. So apart from exams also, in the day-to-day practice, the knowledge of acid-base disorders is what makes you a special doctor compared to the routine doctors. Many of the people or many of the doctors, especially while treating in ICU, they don't give much importance to the ICU. They just look at superficially. They just look the pH. They don't want the actual diagnosis. They don't want to know what is the actually mixed disorders happening in this patient, or what are the other possibilities happening. This ABG is the one thing which can give you a lot of information regarding the patient. And if you can read this ABG very properly, then you can manage the patient very efficiently by considering all of the diagnoses which can coexist in the same patient. But again, it's not like ABG is a gold standard for anything. It's always your clinical judgment. Believe your clinical judgment. Don't be an ABG wanker. So while following this ABG disorders, many of the people think that we need to remember so many numbers and we need to by heart many things. There is no concept, etc. So there are a lot of actually concepts involved in ABG disorders. If you remember the concepts, there is no need to by heart the equations, etc. So just remember the concepts here. So this is a meme which is my personal favorite. Like whenever friends were arguing whether the answer is metabolic acidosis or metabolic alkalosis, while my answer was malaria, this is what everybody's situation is. Even the acid-based questions do come during your VIVA examination from the consultants. So we know the basic function in the body is to have a homeostasis. Body tries to have a balance between everything, like your temperature, blood pressure, osmolarity, pulse rate, whatever the physiological matter you're dealing, the body always try to have a homeostasis, because to function properly, we need to have everything in the normal range. So if something is decreasing, body tries to increase it. If something is increasing, body tries to decrease it. The same thing, this is the basic funda in which the homeostasis works, and this is true for even in acid-based disorders also. So to introduce, our organs and tissues can function properly only under a tightly controlled pH range, that is 7.35 to 7.45. This is a normal human pH in the body. So any deviation from this will be dangerous to the life. The body cell functions is compromised, which might cause harm in many ways. So either it is a decrease in pH or an increase in pH, both are dangerous. So, and depending on this degree of deviation of this pH, body has several homeostatic responses which are activated to trying to restore this normal acid-base status. So if there is increasing acidity, so we have a buffers coming into the play, and we have, if there is a basic level of the fluid is increasing, then there are factors which increase the acidic content of the fluid. So we'll be discussing the simple issues here. So any patient of any disorder of these acid-base balances, there are many factors which impact the prognosis. Like all patients and all diagnoses are not same. So it depends on the severity. If there is more severity, then the harm is definitely more. And the acuity and duration of the derangement, like if something happening acutely can be more dangerous than the chronic thing which is going since years. And the functional status of the kidneys and lungs. The very most two important organs, if at all important in case of acid-base balance, is the kidney and lungs. These are the main things which actually helps to balance the acid-base status. So, and the underlying cause is also important for the prognosis. Like a plasma pH of 7.1, which is an acidic pH, can be inconsequential caused by DKA, which may not be more dangerous. But if this, even this 7.1 pH caused by a shock or a septic shock or a poor organ dysfunction, this might land up in a sudden death of the patient. So the underlying cause is also important. As I discussed in the last class, even 7.1 pH will not warrant the administration of bicarbonate in case of diabetic acidosis, whereas the same amount of pH, if observed during the septic shock, which might be very problematic for the patient. So likewise, if the patient has an anxiety hyperventilation, where the patient is washing more of CO2, is expected to have mild respiratory alkalosis by causing the CO2 washout. So which may be inconsequential. Patient may not be having any problems, just his anxiety-induced hyperventilation. Whereas the same amount of alkalosis, which is caused by a brain tumor, which is involving the respiratory area, by causing central neurogenic hyperventilation, the patient can have a sudden death. So we know that any patient who is breathing very rapidly, we need to rule out the brain tumor. They're expected that they might have the brain metastasis or the primary brainstem tumor, which is involving the respiratory area, which can cause a very life-threatening sudden cardiac death. So the underlying disease is also important, which warrants the management. So if you know the chemistry and if you remember from the physiology which you have learned, so acid is any substance that has at least one hydrogen ion, and it can donate a hydrogen ion when in a solution. And the reverse goes at the base, which can accept the hydrogen ions. So depending on the power, the acids and bases have been categorized into strong acids and the strong bases. So if the more H plus it can donate, it will be called a strong acid. If more hydrogen it can accept, it can be considered as a strong base. The fluids in case of our body, in both the extracellular and intercellular fluid, are relatively weaker kind of acids and bases. They are not very strong acids. So physiologically, there are two classes of acids which are produced in the body. Like metabolism, while we go through the metabolism of carbohydrates, the proteins and the fats, the acid generation do occur. So these acids actually generate in two forms, like volatile acids and fixed acids. So the main volatile acid which is produced while the metabolism is usually the carbonic acid, which is volatile, that it can be vaporized and it can be excreted through your lungs. Whereas the fixed acids, so these has to be excreted only by the kidneys. These cannot be excreted through the lungs. So the volatile acids are mainly produced by the metabolism of carbohydrates and fats. Whereas the fixed acids are usually generated in case of metabolism of proteins. So if you see the amount of this acid production in the body, so daily there is 10,000 to 15,000 milliequivalent of carbon dioxide production during the normal metabolism. During your basal metabolism, even this much amount of carbon dioxide is produced. So the bimetabolism of proteins, on the other hand, is generates the fixed acids. So we know that the volatile acids can be vaporized. So the lung is the main organ which eliminates the volatile acids, whereas the kidney is the main organ which is capable of eliminating the fixed acids. So we know that the daily metabolism of carbohydrate and fat together is much more than the metabolism of proteins. So obviously the generation of volatile acids is more than the fixed acids. So if you compare the amount, the volatile acids production is pretty more compared to the fixed acids. So which actually results in the lungs being the more important organ than the kidneys whenever there is an acute deterioration is compromised. The kidneys come into the picture very late. The immediate action is usually taken by the lung to excrete the acid. And we know the approximate the loss is concerned. The total average extracellular level of hydrogen ions to the overall metabolism is usually 40 nanoequivalents. So body is exposed to tremendous amount of the acidic pH during the day-to-day metabolism also. So if you see the organs, that is lung and kidney, among this, the lung is the very, very important thing in the initial part of your balancing the respiratory, balancing the acid-base imbalances. As you see, like if a patient has a severe acute respiratory failure, maybe secondary to a sudden airway obstruction or a severe ARDS, it results in a significant rise in carbon dioxide and a corresponding drop in pH that could overwhelm the cellular buffers and the kidneys acute compensatory capabilities. We know because lung was the main organ in initial part of the balancing acid-base balance. Whereas if there is a renal failure, there is a consequent inability to excrete fixed acids which come late into the picture. So if the lungs are properly functioning very properly, in a case of acute renal failure, the acid-base imbalance does not develop very suddenly. It takes pretty long time. Only after overwhelming respiratory effort, if it is not correcting, then only it manifests. Whereas in case of a respiratory disease, especially if this is severe enough to cause the functioning disability to buffer the system, it will cause a significant amount of the damage to the patient. So everybody might have gone through this Henderson-Asbel equation, that any pH of any solution is the negative logarithm of this H plus concentration. So this H plus concentration is basically coming from the carbonic acid, which degenerates into bicarbonate and H plus. So after all logarithmic transformation, we know this is the equation which we are dealing with in day-to-day life. The pH is mainly dependent on the log of the amount of base and the amount of acid in the body. So pH is directly proportional to the amount of base. Like as the base increases, the pH increases, which causes alkalosis. As the acid increases, the pH decreases because the denominator increase, the overall product will decrease. So the pH is directly proportional to the amount of base and inversely proportional to the concentration of acid. So in our body, in day-to-day life, and to remember for a remembrance purpose, for basic things, like we consider the bicarbonate as a basic thing and carbon dioxide as an acid thing. So instead of base, you can write bicarbonate concentration. Instead of acid, you can use the carbon dioxide concentration or a partial pressure of carbon dioxide here. So as of the homeostatic responses is concerned, any derangement when occurs, the H plus concentration is corrected timely and in a stepwise approach and in a predictable manner. Like if anything deviations from the normal thing occur, the first comes the picture by the chemical buffers. So buffer is any solution which resists a change in pH. So these are the first thing which comes into the picture whenever there is an imbalance between the acid-base status of the fluid. So this is basically by the three systems. One is the bicarbonate system, which is the main buffering system in the extracellular fluid. And we've got a phosphate system. This is especially true in case of an intrarenal acid-base balance in the cells of the kidney. Then the proteins, it is the main buffering system in case of the intracellular fluid. So usually any minimal change, any slight change in the acid-base balances is usually overcome by the action of the buffer system. Buffer system can take care of a minimal change of any acid-base imbalances. If this response is not sufficient to have the good balance, then the pulmonary thing comes into the picture. So your lungs starts to act to balance thing. So it typically begins in the first hour, and it is fully established by the 24 hours. So how it tries to manage the thing is only by altering the rate and depth of the ventilation. So only by altering the rate and depth, it can manage the acid-base imbalances. Unlike kidney has got many functions. It can secrete H+, it can reabsorb bicarbonate, it can secrete ammonia. It can do many things to have an acid-base balance, whereas lung can do only one thing, either by altering the rate and depth of the ventilation only, either by increasing the respiratory rate or by decreasing the respiratory rate. For example, if there is an increase in the acidity of a fluid, so body wants to wash this acid, whichever there is extra in the body, by increasing the respiratory rate and wash out by doing the washout of CO2. In case of an alkalosis, it tries to do the reverse thing. In case of an alkalosis, body wants to keep the acid, so it decreases the respiratory rate. In 50 to 70% of things, usually the respiratory compensation can handle the acid-base imbalance, but usually it is not sufficient. It can only manage up to 50 to 70% of imbalances. The final and a complete control is usually achieved by the kidney. So the initial best thing is the lungs, but the most complete thing is always kidney. The kidneys won't live till the pH comes to normal. That is why we are alive. That is why we are exposed. Even we are exposed to so many day-to-day life imbalances, we are functioning normally. That is because we have got a normal functioning kidneys. So kidneys can take care of your acid-base imbalances very perfectly, but not suddenly. It takes time. Like it takes around 3 to 5 days. So how it can do? It can do by three things, like H+ excretion. If there is more H+ in the body, that is more acidity in the body, it can directly secrete this H+, especially in case of a distal tubule. If there is no enough bicarbonate to have a neutralization reaction, it can reabsorb more bicarbonate in the body. The kidneys can even produce the new bicarbonate. So this is what the acetazolamide inhibits. So the kidneys can do many of the functions to have the renal acid-base balance back to normal, but it usually begins in like 4 to 5 hours after the thing, and the respiratory compensation is overwhelmed, and it will be continued for 3 to 5 days, and it will be complete. So with this basics, we'll be going through the discussions here. And the first thing is the definitions. You should know what is the definition. So before going into definition or before going into further discussion, for all the practical purposes, the carbon dioxide is an acid, and the respiratory system is the main organ in charge of its the homeostasis, and bicarbonate is an alkali, the kidneys being the main in charge of its homeostasis. Lungs cannot excrete the bicarbonate, it can only excrete the carbon dioxide. So bicarbonate is by kidneys, and CO2 is by respiratory system, that is lungs. So many of the consultants wants to know the difference between the acidemia and acidosis. What is the difference? The acidemia is a state of low plasma pH, whereas acidosis is a disorder which predisposes to low systemic pH. So if you want to know what is the actual difference, so I will give an example. Acidemia, whenever the pH is always low, so all the diseases which can be labeled as acidosis can also be labeled as acidemia, but only if the pH is low. If at all the pH has been corrected by the compensation, the state has been gone, low pH state has been gone, but disorder is there, then only it is called as acidosis. For example, the diabetic ketoacidosis may not have an abnormal pH. It can be normal, but we know it is a state of an acidosis. Only when the pH goes below 3.5, we call it as acidemia. In some diseases, the thing can be compensated and the pH might have brought back to normal. So then we call it as an acidosis. Same with the alkalemia and alkalosis. Alkalemia is an actual state of this high plasma pH, whereas alkalosis is a disorder which predisposes to high systemic pH. So we have got mainly four basic primary acid-base disturbances. So whenever we use a term metabolic, it is mainly concerned about the serum bicarbonate concentration. And whenever we use the term respiratory, this is primarily concerned with the carbon dioxide. So metabolic acidosis is a disorder which predisposes to low pH by having a low serum bicarbonate concentration. Whereas in case of alkalosis, it is a disorder that predisposes to high pH by having a high serum bicarbonate concentration. In case of respiratory acidosis, the primary disability is in the carbon dioxide. If the carbon dioxide is high, so it is respiratory acidosis. If the respiratory alkalosis, in case of respiratory alkalosis, the carbon dioxide concentration will be low. So this is the primary definition. So to remember, the metabolic things are mainly concerned with the bicarbonate. The respiratory things are mainly concerned with the carbon dioxide. So bicarbonate is a base and the carbon dioxide is an acid. So metabolic acidosis, as I told you, is a primary cause is because of decrease in the bicarbonate. So this produces the low pH. So trying to compensate for the low bicarbonate, the body tries to wash out the carbon dioxide, which can cause the low PCO2 in the body. In case of metabolic alkalosis, the primary disorder is concerned with bicarbonate, which is an increase in the bicarbonate. So since the alkali content is more, body tries to preserve the acid, that is carbon dioxide, which increases the carbon dioxide concentration as a compensatory response. In case of respiratory acidosis, the primary thing is the increase in PCO2, that is increase in acidity. So body tries to absorb more of the base through the kidney, that is by increasing the bicarbonate concentration. In case of respiratory alkalosis, so there is a CO2 washout. So body tries to wash the bicarbonate in the kidneys. So if you can't remember this, the concept, as I told you, the pH is directly proportional to the log of bicarbonate and CO2. Since the ratio should remain constant to have a low pH, and whenever the one thing decreases, the other thing should also decrease, and whenever the one thing is increases, the other thing should also increase as a part of compensatory response, only when the pH remains normal. So if the numerator is decreasing, the denominator should also decrease, and the numerator is increasing, the denominator should also increase to keep the final ratio constant. And if you can remember in another way, which many of the people remember, in case of the compensation response, you should know the direction of the pH and direction of the carbon dioxide. If the pH and the carbon dioxide directions are same, it is usually a metabolic process. For example, in case of metabolic acidosis, the pH is also low, the carbon dioxide is also low. In case of metabolic alkalosis, the pH is also high, carbon dioxide is also high. So in metabolic acidosis, the both goes in the same direction. Whereas in case of respiratory things, the pH and carbon dioxide goes in opposite direction. In case of respiratory acidosis, there is pH is low, whereas carbon dioxide is increased. In case of respiratory alkalosis, the pH is high, whereas carbon dioxide is low. So both goes in the opposite direction in case of respiratory things. So to remember easily, the mnemonic here is ROM, that is respiratory for opposite. So remember the relation. It is direction of the pH and PCO2. This you should remember. This is not the relation between bicarbonate and pH, and not the bicarbonate and carbon dioxide. It is between the pH and PCO2. So in respiratory syndromes, the pH and PCO2 are in the opposite direction, whereas in metabolic syndrome, the pH and PCO2 are in the same direction. I think I'm clear till now. So to go further, as I told you, for any primary decompensation, there is always a compensatory response. And this compensatory response is not haphazard. It is always appropriate and predictable. So body behaves in a predictable way to correct the primary cause. So we should know how the body behaves. Then only we can know what is actually happening in the body. So in case of metabolic acidosis, we know the primary thing is the decrease in bicarbonate. So every 1 millimole fall in bicarbonate, the PCO2 fall by 1. In Harrison, it is also considered as 1.25. So you can remember both things. In case of metabolic alkalosis, every 10 millimoles rise in bicarbonate increases the PCO2 by 7. In case of respiratory acidosis and alkalosis, they can have acute or chronic things. In case of respiratory acidosis, we know that there is an increase in PCO2. In case of an acute thing, every 10 mmHg rise in PCO2 increases the bicarbonate by 1, whereas in case of chronic respiratory acidosis, every 10 rise in PCO2 increases the bicarbonate by 4. So the ratio is simple. In case of acute respiratory acidosis, it is 10:1 and 10:4. In case of respiratory alkalosis, the acute thing, in every 10 mmHg fall in case of bicarbonate decreases bicarbonate by 2, whereas in case of chronic respiratory alkalosis, every 10 fall in PCO2 decreases the bicarbonate by 5 millimoles per liter. So this is very important to remember here, and this is a must remember slide, and this is a slide which you should revise just before going to exams, because if you remember this, then only you can calculate the compensation. In some books, it is given per mmHg rise in PCO2. Like if you go to a Harrison table, per mmHg rise there is a 0.1, per mmHg rise there is a 0.4. But the basic funda is here. I have taken the 10 because it is easy to calculate. So today, as I told you, we will be discussing the metabolic acidosis. So in case of a metabolic disease, the degree of respiratory compensation, it can also be predicted by this formula. And this formula is a very, very important formula. This is also called as Winter's formula. Any acid-base imbalance question, you need to remember this particular formula. The PCO2 is equivalent to 1.5 times the bicarbonate plus 8 plus or minus 2. This is how we are going to calculate the PCO2 correction in case of metabolic diseases. Either it is a metabolic acidosis or a metabolic alkalosis, to know the compensation. As I told you here, for every simple things, for every 1 millimole fall in bicarbonate, the PCO2 decreases by 1 mmHg. But for a calculation purpose, this is usually considered. Harrison also gives the simple formula, which is the predicted carbon dioxide concentration is equivalent to the bicarbonate plus 15. You can even use this formula while calculating, whichever you remember. But it is always preferable to use the main Winter's formula, that is 1.5 times the bicarbonate plus 8 plus or minus 2. Even if you don't remember this plus or minus 2, it's okay. Just remember it is 1.5 times the bicarbonate plus 8. So why this is important, I will give you an example here. If a patient supposedly has a metabolic acidosis with a pH of 7.2 and bicarbonate 12, so he is expected to have the carbon dioxide concentration of how much? So it is 1.5 times the 12 plus 8. 1.5 times the 12 is 18. 18 plus 8, it is 26. So plus or minus 2 is 24 to 28. So your bicarbonate should be, your carbon dioxide should be in the range of 24 to 28 mmHg. If at all in your patient, if you see the bicarbonate less than 24, that means he is washing more CO2 than much expected. So he is considered to have a respiratory alkalosis along with the metabolic acidosis. Whereas if the patient has more PCO2 than the expected, he is retaining this CO2 by having a component of respiratory acidosis along with the metabolic acidosis. So this is very, very important, and this is very simple. If you remember this, this is more than enough, because if at all they have, they're framing a question on acid-base balances, it's usually metabolic acidosis. They usually don't want to discuss the primary metabolic alkalosis or a primary respiratory alkalosis, especially. It is usually metabolic acidosis or the respiratory acidosis with some accompanying abnormality, which you can calculate very easily after the end of this class. So we know the primary disturbances here. The metabolic thing is mainly because of bicarbonate. The respiratory thing is mainly because of carbon dioxide. And we know the compensation. In case of metabolic acidosis, the expected carbon dioxide concentration is usually 1.5 times the bicarbonate plus 8 plus or minus 2. I think you all are with me in this discussion. This is an acid-base nomogram. Even this can be used to calculate the compensation. You can just locate where your patient are in this particular chart. Like the y-axis is represented by the pH, and the x-axis is represented by the bicarbonate here. The normal pH corresponds to 7.4 with bicarbonate 24. So this is usually the center part of this acid-base nomogram is usually normal pH. So this graph usually looks like it is drawn from a paint brush from one end to the other. So this can also be used to calculate the patient's status. For example, if the patient has a pH of 7.2 and if he has bicarbonate 12, so this patient will be landing here. So you can, whenever the patient falls directly within this paintbrush shades, they have an isolated, they are considered to have an isolated abnormality. Whenever they fall out of what you call the paintbrush areas, they are usually considered to have mixed acid-base disorders. So this is usually not used in case of anything, the day-to-day practice, but everybody should know this thing. So this is again a Davenport diagram, which is a one kind of what you call acid-base nomogram. The concept is being the same here. The pH and bicarbonate have been drawn. The center part usually represents a normal pH. So to have a stepwise approach in evaluating acid-base disorders, we should know how to proceed with the assessment here. First, always obtain the ABG and electrolyte simultaneously to check the validity. For example, some factors you will be getting in both the electrolytes report and ABG reports. For example, bicarbonate, you can check the accuracy of the ABG and electrolytes here. The both should correlate. If there is a bicarbonate level and ABG report are mismatching, so there is abnormal report, consideration is done here. So you can repeat the test. So always consider the ABG and electrolytes and verify the accuracy of ABG before going into further proceed. And the first thing after this is usually the what you call the identifying the primary disorder and the compensation. And if there is a metabolic acidosis, then always evaluate the anion gap. So if not normal, it is corrected for albumin of 4.5 gram. We'll be discussing it. And know the main 4 causes of high anion gap metabolic acidosis, and know the main 2 causes of non-anion gap metabolic acidosis, and estimate the compensatory response, calculate the delta gap. All this process go and go and go. So to be basic thing for every acid-based question which you follow, don't predict the answer just by looking at the question. Always calculate. This is what the most people do. They just try to rule out the options. This usually works for many of the things, but ruling out option usually does not work in case of acid-based questions. Always go from first point to the end point to calculating the acid-base imbalance in your patient. So to clear the concept of anion gap here, as I have considered this anion gap discussion very important here, because many of the people don't understand what is anion gap. Even when I was UG, I had a difficulty in understanding what is anion gap, so I used to leave this topic. But it is actually very easy. So as I told you in my first slide, the main basic funda in the body is having homeostasis. So it is same true for having the positive ions and negative ions in the body. So in any particular fluid, the anions must be equal to the cations. So this is the basic funda. So amount of anions is usually equivalent to an amount of cations. We know that the major cation in our body, especially in case of an extracellular fluid, is usually sodium, and other things are usually negligible. So we measure the sodium. In case of an anions, we can only measure chloride and bicarbonate, whereas some anions we can not measure routinely. So that is called as unmeasured anions, which is usually formed by albumin or phosphate, sulfate, and some proteins. So this unmeasured anion is usually considered as anion gap. So anion gap is usually the bicarbonate minus chloride plus bicarbonate. So this usually gives the amount of unmeasured anions in your body. So why this is important, why this concept came into the metabolic acidosis? Because whenever we were calculating or we were predicting the acid-base responses in our patient, we can work till the patient have the diagnosis of metabolic acidosis or whatever the mixed acid-base disorders they have. But after having the metabolic acidosis, to proceed further, what kind of metabolic acidosis patient is having, because we have got innumerable number of causes for metabolic acidosis. So we'll be discussing it in further during this lecture. So I think we have got more than 100 causes of metabolic acidosis. So to differentiate or to narrow them to the main causes, we many of the scientists calculated this thing that is involved this concept called anion gap. So this concept is mainly used in case of a metabolic acidosis, whereas this can also be used in case of metabolic alkalosis, etc. So there are many things which you can diagnose by the anion gap. So anion gap is calculated by sodium minus chloride and bicarbonate. So I have told you in the last class also, some books also adds potassium into the cation group, but the basic what you call a discussion in case of the American society guidelines or whatever the American textbooks you are studying, they only use the sodium. Whereas if you see any European books like British, etc., they have the potassium included in it. In this won't change any what you call the approach or the differential diagnosis or the anion gap number. It remains same. But for all practical purposes, we are using the American purpose only here. So this is sodium minus chloride plus bicarbonate. So even for exams, I recommend to use this particular formula because it is very simple and it keeps things very simple. Otherwise, it becomes very difficult to remember all the things. So don't try to mug up all the things. So just remember this anion gap is just sodium minus chloride plus bicarbonate. Always remember this to correct for the hypoalbuminemia. As I said you, the major unmeasured anion in case of our body is the albumin. Whenever we are having an hypoalbuminemia, we might underestimate the anion gap. So we should correct it for the normal albumin. Okay. So to understand the concept further, as I told you, the anion gap is the unmeasured concept, unmeasured anions in the body. So our metabolic acidosis in the bodies are usually categorized into normal anion gap metabolic acidosis and high anion gap metabolic acidosis. That means in some metabolic acidosis disorders, your anion gap remains normal, whereas in some high anion gap metabolic disorder, it increases. So why this occurs? Because in case of high anion gap metabolic acidosis, it is usually due to an accumulation of an extra acid, so which is usually accumulated in the protein section, so which increases the anion gap. Whereas in case of normal anion gap metabolic acidosis, the chloride is usually increased along with the increase in the what you call usually bicarbonate excretion in the body. So this is what the main funda. The chloride remains normal. Chloride increases in concentration. So that's why this is also called as a hyperchloremic metabolic acidosis, which is non-anion gap metabolic acidosis. So the increase in chloride compensate for the anion gap here. Whereas in case of high anion gap metabolic acidosis, the chloride cannot compensate. So that just extra acid goes on accumulating in your body. So for example is diabetic ketoacidosis. So in case of a diabetic ketoacidosis, the ketones bodies just accumulate in the body, so which increases the anion gap. Whereas if you take some causes for non-anion gap metabolic acidosis, like the renal tubular acidosis, body just cannot secrete the H plus out of the body. So this to manage this, the chloride ion increases in your body. So as I told you, the positive is equivalent to negative in the body. So more the H plus, the more the chloride it combines with, so it increases the chloride concentration. So this is called as an hyperchloremic metabolic acidosis, which is usually a non-anion gap metabolic acidosis. And next, the concept of delta ratio came, especially in case of high metabolic acidosis. Here, as I told you, body always do the things in predictable way. Body does not do the things in haphazard way. Whenever there is a decrease in bicarbonate, there is increase in anion gap. This relation is predictable, like the amount of bicarbonate should go hand in hand with the increase in anion gap. So increase in anion gap should correlate with the decrease in bicarbonate. For example, if you see this, your anion gap has increased to 20, there is 9 increase in anion gap, whereas bicarbonate has decreased from 24 to 15. So there is 9 degrees in case of bicarbonate. So this ratio should go hand in hand. If the ratio is not going hand in hand, so there is an accompanying other disorder which you should consider here. That is why the concept of delta ratio came into the picture, or delta gap, both are same. So if you see the delta ratio, it is just a ratio of change in the anion gap to the ratio of change in the bicarbonate. As I told you, the ratio should go hand in hand. So the ratio should always remains 1 in case of a pure anion gap metabolic acidosis. Whereas if the ratio is not going hand in hand, the ratio is more than 2, or if it is less than 1, then you should suspect the coexisting disorder. So as I told you in simple terms, the delta ratio is nothing but a relation between the increase in anion gap and decrease in bicarbonate. So it is usually used to know the coexisting acid-base abnormalities in case of a high anion gap metabolic acidosis. So the concept of delta ratio is to be used only in case of high anion gap metabolic acidosis. Please remember it. So this delta ratio is basically the difference in the or the increase in the anion gap or decrease in the bicarbonate. So normal anion gap is 12 and normal bicarbonate is 24. So we are using this, the anion gap minus 12 divided by 24 minus bicarbonate. So we'll be discussing a lot of questions in the end. Then it is very easy to understand for you people. So if the delta ratio is 1 to 2, so this is normal. So this is a pretty predictable response. So this is a pure or isolated high anion gap metabolic acidosis. If the ratio is less than 1, that means if the increase in anion gap is less than the decrease in the bicarbonate, there is a coexisting metabolic alkalosis. And if the delta ratio is more than 2, then there is a coexisting both non-anion gap metabolic acidosis and a high anion gap metabolic acidosis. So this is also very, very important. By delta ratio, we can calculate the 2 mixed acid-base disorder, that is metabolic acidosis, high anion gap metabolic acidosis with metabolic alkalosis, and high anion gap metabolic acidosis with non-anion gap metabolic acidosis. So even though these both are the different entities, but these both can coexist in the same patient. So that is what the beauty of this medicine. It looks very complex, but it is very easy if you understand the concept here. So as I told you, the today discussion is mainly about the metabolic acidosis here. Whenever we have a metabolic acidosis, our pH usually goes below 7.35, our bicarbonate goes below 22, so 24, or bicarbonate, carbon dioxide excretion increases, so it goes below or less than 35 as a compensation. This is just an example here. This is not a true value. So the pH decreases, the bicarbonate decreases, and the carbon dioxide decreases in case of metabolic acidosis. So you should know the expected compensation. So as I told you, we are using the Winter's formula here, that is 1.5 times the bicarbonate plus 8 plus or minus 2. So this will give the level of compensation, whether it is appropriate or is there any associated diseases or not. So after having this, we are calculating the anion gap. So I think I have cleared the concept of anion gap. Anion gap is nothing but the amount of unmeasured anions in your body. So to have an equations to calculate anion gap, as I told you, we are using 2 different equations. One is Europe or UK based, and one is the USA based. So we are using the formula which is given below. That is, anion gap is equivalent to sodium minus chloride plus bicarbonate. So the normal value is considered as 12 plus or minus 2, that is 10 to 14. So and normal anion gap is considered as 10 to 14. Whereas if you use the UK based equation, the normal anion gap is considered from 8 to 16. The range increases here, so it is very difficult for calculation. The range should be narrow to have a good prediction. So I prefer to use the American based equation. Even Harrison gives this equation. And we should correct it for the albumin level if at all it is low. And here also response is predictable, like for every 1 gram decrease in albumin, your anion gap is decreased by 4 millimoles. So we need to compensate it for the low albumin. So we'll be discussing it. So as a final result, we'll be having either a high anion gap metabolic acidosis or a normal anion gap metabolic acidosis. So if there is a high anion gap metabolic acidosis, then we will be calculating the delta ratio, as I told you. In case of, if at all there is a normal anion gap metabolic acidosis, then we will be calculating the urine anion gap. This will be, I think it is better to consider here the concept of urinary anion gap. So as I told you, in case of the normal high anion gap metabolic acidosis, to know the differences or the differential diagnosis, we calculate the delta ratio to have any coexisting thing or not. In case of the normal anion gap metabolic acidosis, to have further prediction, we usually calculate the urine anion gap. So coming to the major causes of the metabolic acidosis. So this particular table, I have taken it from up to date. Remember, this is also one table which you should revise before going into any entrance exam, because the question is definitely going to come with this table. There is a lot of potential in this exam. So to have a metabolic acidosis in your body, we need to have three major abnormalities. Either there is an increased acid production in the body, or the loss of bicarbonate, that is an alkali, from the body, or the kidneys cannot excrete the acid which is normally produced in the body. So the most common, it is usually the increased acid production. And if you remember here, the most common causes of the increased anion gap are usually the increased acid production in the body. Whereas in case of normal anion gap metabolic acidosis, the most common causes are like either loss of bicarbonate or the decreased renal acid excretion. So the main causes of the increased anion gap metabolic acidosis are the actual increased acid production in the body. Among that, the most common is usually lactic acidosis, because whenever there is a high tissue, low tissue perfusion or a hypotension or a shock, body switches from aerobic metabolism to anaerobic metabolism. So at the end of anaerobic metabolism, we end up with a lot of lactate being produced. So which adds up to your acid pool in the body, which increases the acidity of the body. So same with the ketoacidosis, there is a lot of production of the ketones, especially in case of an uncontrolled diabetes mellitus or a starvation. Their bodies does not have enough fuel for their survival, and switch to the anaerobic metabolism, again causing the lactic acidosis and also the ketones. And same with the alcohol. So the ketoacidosis can be seen in case of uncontrolled diabetes, the starvation, and the alcohol associated things. And ingestion of many things, majorly the alcohol things, usually causes metabolic acidosis. We know methanol, which is a wood spirit, which is very dangerous, usually cannot be metabolized from the body, where it can directly increase the production of acid and cause severe retinal damage and severe metabolic acidosis and sudden death of the patient. The next is ethylene glycol. Ethylene glycol is a very important question for the entrance exam. Everything related to ethylene glycol should be known by the UGs before going to exam. The ethylene glycol is usually found in case of the antifreeze things, whatever the antifreeze elements are used. The poisoning is also very common. This ethylene glycol is usually metabolized by the same enzyme which metabolizes the alcohol, that is alcohol dehydrogenase. So in alcohol dehydrogenase converts this ethylene glycol into toxic acids, so which are very dangerous and causes kidney failure and your crystalluria and all the things, etc. And aspirin, the salicylates are expected to cause the metabolic acidosis, especially in the severe stage of the poisoning. The early stage, it is usually it causes respiratory alkalosis because of hyperventilation. In late stages, it causes metabolic acidosis. I think this is known by everybody in their pharmacology section when they were studying aspirin. So that time we used to by heart the things like this. First it causes respiratory alkalosis, then the severity increases, then it might lead to metabolic acidosis. But to remember shortly, aspirin, late stage it causes the high anion gap metabolic acidosis. In early stage it causes respiratory alkalosis. So the toluene, Tolvin, I think the many of us know that is usually used in a glue sniffing. We know these glues are used by the sniff to have an immediate what you call effect. The recreational agent, it is used very commonly in case of the younger generation. I think before 10 years, we did not have any major cases of Tolvin, but after, in the recent 10 years, the glue sniffing amount has been increased, especially in case of even the low socioeconomic status, those who cannot, those who cannot have their daily food, those who are cannot control their hunger, they usually do the glue sniffing. If you just sniff this Tolvin, it can cause an immediate hallucination. So this is a very potent compound which can impair the kidney function in the early stage, and it can later get converted into potassium hypochlorite in the urine. So this is a very important cause for increased anion gap acidosis also. And diethylene glycol is a one alcohol compound which can cause the metabolic acidosis. And propylene glycol. Propylene glycol is a very important one because this is being used in many IV injections which we usually give the patients, like many of the anticonvulsants like heptoin, the sodium valproate, the levetiracetam. So many of the injections are usually having the component of propylene glycol. So this propylene glycol, whenever we are using in a ward-to-ward basis, it is usually not observed. But whenever we are giving the patient the continuous infusions, so this toxicity is usually expected. So if the patient is on continuous infusion of any propylene glycol containing injection, so you should be careful in monitoring the acidosis. So there are many case reports where the cause of the metabolic acidosis could not be identified, but later it was found out to be the continuous infusion of like noradrenaline or some propofol injection which has been going to the patient which had propylene glycol in the injection. We know that lactic acidosis, the lactate which is produced in the human body is usually the L isomer, whereas in some bacteria, if at all the patient is bearing in his intestine, this can convert the lactic acid of L isomer into D isomer. Although it is very rare, this can also cause what you call the high anion gap metabolic acidosis. And again, pyroglutamic acid or 5-oxoproline. So this is a potential question. So this is still now, I think it has been not asked in the question, but it is definitely a potential question because this is an end product of a paracetamol metabolism. Like acetaminophen is usually converted into pyroglutamic acid in our body. So we know that acute paracetamol overdose is life-threatening. It can cause you fulminant hepatic failure. Whereas a chronic abuse of paracetamol, the patient can have a pyroglutamic acid toxicity and patient can have metabolic acidosis. Again, there have been many case reports of unexplained metabolic acidosis in their patient who found out to be having pyroglutamic acid. Nowadays, they can directly estimate the pyroglutamic acid in many of the what you call the Stanford, Harvard, etc. The emergency medicine people, whenever they have a metabolic acidosis, they directly estimate pyroglutamic acid and always consider this as one of the differential diagnosis. So whenever the patient of old age who is what you call osteoarthritis, etc. So many of us know that NSAIDs should not be used for a long term, but instead of that, they were given paracetamol. So they will be giving this paracetamol. They will be taking the paracetamol of 1.52 grams per day for like 5 to 10 years. So this patient might come to you suddenly with a complaint of fatigue. Patient can have a nausea, vomiting, which is unexplained by any of the condition. You have tried to rule out all of the possibilities, but you the only thing was metabolic acidosis, which is a clue. So to rule out the pyroglutamic acid toxicity, and the only treatment is the stopping of the paracetamol and just supplementing the patient for short term with the bicarbonate relieves the symptoms. So this is a very important thing. So acute paracetamol toxicity, we know there are, I think, 10, 12 questions can come with this, but whereas chronic paracetamol overdose, I think till now it has not been asked, but this is a growing trend to have a pyroglutamic acid toxicity induced metabolic acidosis in the patients. So the chronic paracetamol poisoning can cause the pyroglutamic acid toxicity. It is one of the cause for increased anion gap metabolic acidosis. So whatever the things we considered here are the main causes of increased acid productions here. They usually causes high anion gap metabolic acidosis. if you have the next most common, that is the loss of bicarbonate in the body, so it is usually either through the kidney or through the GI tract. If the patient has an excessive loose stools, diarrhea, or if the patient has a stent from the urinary system to the intestine system, which is usually done in sigmoidostomy to bypass the urine, the loss of bicarbonate gets urine, because urine is drained through the what you call intestines. So this is a very common cause of the loss of bicarbonate. And the next most common causes are the RTA, that is the renal tubular acidosis, especially the type 2 RTA, that is proximal RTA, is mainly because of loss of bicarbonate reabsorption. In type 1, it is usually decreased acid secretion, whether it is type 2, it is usually loss of bicarbonate secretion. And the next common cause is kidneys cannot excrete the acid which are normally produced in the body. So again, the kidney failure can cause both a high anion gap metabolic acidosis and a normal anion gap metabolic acidosis. But for all practical purposes, if the examiner wants the single answer, if anybody asks you what is the type of metabolic acidosis in case of kidney failure, we are using it as an increased anion gap metabolic acidosis. Only in kidney stage 3, the normal anion gap metabolic acidosis is there, because in case of the kidney failure, the basic concept is the glomerular filtration cannot happen and kidneys tubules cannot reabsorb whatever the filtration is going on. That is what the kidney does, right? It filters, then it reabsorbs or secretes. So in case of kidney failure, it is not filtering enough, and even if it is filtering, it is not reabsorbing or secreting enough. So the body, whatever the bicarbonate is going or filtering through the glomerular filtrate, which is not reabsorbed. So in case of a CKD or a chronic kidney disease, the tubular dysfunction occurs much earlier than the glomerular dysfunction. So in case of an early stage, like stage 3, 4, so many of the glomerulus is working pretty good, whereas the tubes have already gone into the dysfunction, which can usually manifest as a tubular acidosis picture, that is normal anion gap metabolic acidosis. Whereas in case of a severe kidney failure, when the glomerular filtration rate decreases profoundly, they usually manifest as an increased anion gap metabolic acidosis. So if the examiner specifically wants the question in case of an early stage of CKD, he is mentioning the word early, you can go for the normal anion gap metabolic acidosis. Whereas if the examiner is using only kidney failure or severe kidney failure, it is the increased anion gap metabolic acidosis for sure. So, so many of you are fond of the what you call these. I don't usually like these remember the things like this, but the Kusumel is one thing which you can remember to know the causes of the high anion gap metabolic acidosis, and it is also the standard mnemonic. K for ketoacidosis, U for uremia, S for sepsis and salicylates, methanol, alcohol, lactic acidosis, ethylene glycol. I think in one Lancet article also this mnemonic came into the picture. They have used this mnemonic. So this is a standard mnemonic. The Kusumal, you can remember this. And the mud piles is also, cut mud piles is also the mnemonic for knowing the causes of high anion gap metabolic acidosis. So I think we have included all the things here. Some things which are not there in that what you call chart from the up-to-date was this carbon monoxide, cyanide, and congenital heart failure. So this is basically the hypoperfusion which is leading to lactic acidosis, causing the acidosis. There is no extensive different mechanism. Whereas this aminoglycoside-induced metabolic acidosis, we usually expect aminoglycosides are tubular toxic drugs which can cause acute tubular necrosis, etc. So they are expected to have a normal anion gap metabolic acidosis. So I tried to search through a lot of literature. I could not find out how the aminoglycosides came into this picture and how the aminoglycosides are causing high anion gap metabolic acidosis. So I don't know whether aminoglycosides actually causes high anion gap metabolic acidosis or not. Even we have not seen anything. If at all we have seen it is normal anion gap metabolic acidosis may be directly presenting as the acute tubular necrosis, especially in case of gentamicin, capreomycin, etc. And iron, again, the iron toxicity manifests through the oxidative stress and generation of a lot of reactive oxygen species. And the INH toxicity again causes the reactive oxygen species generation, and the what you call bodies cannot function properly, cells cannot function properly, ultimately leading to lactic acidosis. So these are all indirect causes here. The main chart is this one. If you can go ahead with this one, please remember this chart. So among the normal anion gap metabolic acidosis, to further narrow down the diagnosis, we can have the look of the potassium value. If there is a normal anion gap metabolic acidosis with hypokalemia, then the diagnosis narrows down. It is usually either type 1 or type 2 RTA, or it is an acetazolamide toxicity, or it is an acute severe diarrhea where there is a loss of bicarbonate and potassium both, and the obstruction of artificial ileal bladder, or a dilution acidosis where we are giving a lot of 0.9% NaCl infusion. The patient usually expected to have hypokalemia with normal anion gap metabolic acidosis. But if at all we are seeing the normal anion gap metabolic acidosis with a hyperkalemia, so we should think of mainly two causes here. One is either type 4 RTA or an Addison's disease, that is hypoaldosteronism. So we know that Cushing's causes metabolic alkalosis, Conn's causes metabolic alkalosis, whereas Addison's causes metabolic acidosis. It is as simple as that. There is no complex thing involved here. And other things are like subsiding diabetic ketoacidosis. Like if you are supplementing the patient of potassium, his potassium may be normal and his anion gap settled down, still you are going for fluids, the patient might have an acidosis with a normal anion gap. Again, potassium sparing diuretics are same as Addison's disease. That is what they're causing, isn't it? So potassium sparing diuretics are expected to toxicity can cause normal anion gap metabolic acidosis. So among diuretics, the potassium sparing diuretics are the only diuretics which causes what you call normal anion gap metabolic acidosis. Although acetazolamide is not considered as a pure diuretic, but if loop diuretics and thiazide diuretics mainly causes metabolic alkalosis, whereas potassium sparing diuretics causes metabolic acidosis. So to remember here, first see whether there is a metabolic acidosis or not by seeing the pH, the bicarbonate, and the PCO2 concentration. Then calculate the compensation, whether it is an appropriate or not. Then calculate the anion gap. If at all it is an anion gap metabolic acidosis, then calculate the delta gap for high anion gap metabolic acidosis and urinary gap for non-anion gap metabolic acidosis. So what is this urinary anion gap and how it is going to benefit to know the causes of non-anion gap metabolic acidosis? So if you see the non-anion gap metabolic causes here, the cause is the loss of bicarbonate. So the main narrowing of differential diagnosis is whether this losing of bicarbonate is through the kidney or through any other organ apart from kidney, like the GI tract, etc. So if the body is having the non-anion gap metabolic acidosis, it is either losing the bicarbonate from the kidney or it is losing the bicarbonate from the GI tract. So we know that the urinary anion gap is usually calculated by sodium plus potassium minus chloride. Here potassium is the major concentration along with the sodium in case of an urine, whereas bicarbonate is nil in case of normal urine. The majority of the bicarbonate is reabsorbed, its concentration is negligible. That's why we are not using the bicarbonate concentration in case of the anion formula. Whereas potassium excretion is pretty good in case of, and it is also pretty considerable. So we are using both sodium and potassium level in the case of urine anion gap. Whereas in serum, we can use only sodium. So this chloride concentration, whatever we are measuring, it is usually excreted through the formation of ammonium chloride. So this ammonium is usually indirect evidence of an acid. So body excretes acid through the ammonium. So if there is a more ammonium secretion, that means more acidity. That means there is more chloride. I will come again. The body normally excretes the H+. So if there is an acidosis, the kidney tries to excrete this acid more. So this excretion of acid only goes in the formation of ammonium, and this ammonium then combines with chlorine. We usually don't have a direct measurement of ammonium. If we measure directly the concentration of ammonium, then it becomes very simple. Whereas if we cannot measure the urine ammonium, we have got a surrogate marker, that is urine anion gap, where the if there is more ammonium, the chloride concentration also becomes more, then it becomes negative. That means kidney is excreting acid. So kidney is not the culprit here. It is a GI disturbances which is causing the bicarbonate loss. If at all it is positive, that means there is no enough chloride. That means there is no enough ammonium. That means kidney is not excreting the acid. Even if body has an acidosis, that means the kidney is not functioning properly. It is the kidney which is losing the bicarbonate. That is what the narrowed out here. Although you cannot use it in the section of polyuria, the urinary anion gap will be very disproportionate in case of the polyuria patients. And nowadays, many of the laboratories directly measure this ammonium concentration instead of going for urinary anion gap. So if you see a metabolic acidosis, the first thing is to ask whether it is high anion gap metabolic acidosis or a normal anion gap metabolic acidosis. If there is a high anion gap metabolic acidosis, first thing is always measure the serum ketones. If they're present, then it is ketoacidosis. Either it is alcoholic or diabetic or a starvation. Okay, if there are no ketoacids, then measure the serum lactate. Nowadays, the serum lactate measurement is very important in case of an emergency, because every surviving sepsis campaign, the first hour bundle, we have to measure the lactate. So if the lactate is elevated, then it is lactic acidosis. In the case of high anion gap metabolic acidosis, if the serum ketones are not elevated, serum lactate is not elevated, then you try to rule out the other causes, as I told you, the poisonings, etc. If you see a normal anion gap metabolic acidosis, the next thing is to always measure anion gap. If the anion gap is negative, that means the kidney is able to excrete the acid. That means it is a GI losses. Whereas if the urinary anion gap comes positive, that means kidney cannot excrete the H+. So it is kidney which is losing the bicarbonate. So at the end, we will be discussing some case examples here. I think this is, everybody should know, this is a standard way of writing the investigation reports in case of what you call the many of the textbooks given in the MRCP, etc. So even although till now this pattern has not been used in NEET or any AIMS question, but there is a potential that they may come directly in this kind of picture. So you should know what things comes where. So this is a fishbone architecture we use. So to write a what you call CBC report, we are using hemoglobin, hematocrit, WBC, and platelets. Today's section will be using this, that is the fishbone for electrolytes. The first is always sodium, potassium, then chloride and bicarbonate, then the blood urea nitrogen and creatinine, and in the middle it is always the blood glucose. So with this background, we'll try to solve some questions here. So this is the basic normal values which are given. If you have any confusion, go through this. So the first example is here, the pH is a 7.32, the PCO2 is 28, and bicarbonate is 14, and sodium is 140, potassium is 3.6, chloride is 116, the bicarbonate is 14. So this bicarbonate is from ABG, this bicarbonate is from electrolytes report. So both are same, that means the report is valid. And the blood urea nitrogen is 13, and creatinine is 1, and blood sugar is 100. So if you want to have a diagnosis here, first check the pH. pH is less than 7.35, so there is an acidemia. Check PCO2. PCO2 is decreased, that means it is a metabolic thing. So it is a metabolic acidosis. Then step 3 is evaluate the compensation. As I told you, with the Winter formula, the predicted carbon dioxide is 1.5 times the bicarbonate plus 8 plus or minus 2. So PCO2 comes here 27 to 31. That is in our patient is 28. That is in the normal range. So compensation is appropriate here. Then calculate the anion gap. Anion gap is sodium minus chloride plus bicarbonate. So it is 10. So anion gap, we know that is 12 plus or minus 2 is a normal thing. So anion gap is also normal. So my final diagnosis in this particular patient is normal anion gap metabolic acidosis. So with another example here is a pH of 7.28, bicarbonate is carbon dioxide is 24, bicarbonate is 12, sodium is 128, potassium is 3.8, the chloride is 94, the bicarbonate is 12, the creatinine is 1.8, and the BUN is 20. So patient is having an AKI also here with a blood sugar of 145. So if you check the pH, it is low. Definitely there is an acidemia. Check the PCO2. PCO2 is low, bicarbonate is low, so there is a metabolic acidosis. So step 3 is like evaluate the compensation adequacy. So the carbon dioxide is 1.5 times the bicarbonate plus 8 plus or minus 2. So the carbon dioxide comes in 24 to 28. So here it is 24. So it is well within the normal range. The compensation is appropriate. Then calculate the anion gap. Anion gap comes here 22. So this is a case of high anion gap metabolic acidosis. So in this patient, if you want to go further, although I have not used in this patient, you can go next thing is to calculate the delta gap to know the adequacy. So we'll be using this here. We have got a 32-year-old pregnant woman who comes to the ER with a 4 days of non-stop vomiting. Where the pH is 7.41, PCO2 is 42, bicarbonate is 24. The sodium is 146, potassium is 3.2, chloride is 92, the bicarbonate is 26. Although this is the range is similar, this can be considered as the appropriate. The creatinine is 2.2, the BUN is 19, and the RBS is 132. So if you check the pH, it is normal. So this is not a state of an acidemia. So you cannot use the terminology here acidemia. Whereas PCO2 also appears normal and bicarbonate also appears normal. So it is very difficult to see the primary thing here. So next is always evaluate the compensation here. Next, calculate the anion gap here. Anion gap is 28. So this is a case of high anion gap metabolic acidosis. So as I told you, in the next thing, if you see the patient of high anion gap metabolic acidosis, next calculate the delta ratio. As I told you, the delta ratio is the difference in the change in the anion gap and change in the bicarbonate. So if you take the ratio here, ratio comes to -8. So there is negative delta ratio. That means there is a coexisting metabolic alkalosis. So this is a patient who is having high anion gap metabolic acidosis along with the metabolic alkalosis. So this is a case 4, where there is a 23-year-old woman with a 3 days history of fever, cough with expectoration. The confusion and orthostasis was observed. There is a past history of type 1 diabetes, and there was bronchial breathing observed in the right infraxillary area. So the pH appears normal, the PCO2 is low, the bicarbonate is low. So this is a case of metabolic acidosis, pretty simple here. So next we will evaluate the compensation adequacy. So here compensation is 29, we have got 29, but the PCO2 value is very low here, that is 24. That means there is an excessive PCO2 washout than required. So the patient also has a coexisting respiratory alkalosis here. So since there is a metabolic acidosis also, so we are calculating the anion gap. So anion gap is 20 here. So there is a high anion gap metabolic acidosis. So as I told you, the high anion gap metabolic acidosis should be calculated as a delta ratio. Here the delta ratio is 1. So it is a pure high anion gap metabolic acidosis along with the respiratory alkalosis, because the compensation is more than the expected here. So if you take the next example, there is a 48-year-old woman is found unconscious next to an empty pill bottle at home. While after coming to the hospital, she was severely acidemic. PCO2 was 34, the bicarbonate was 10. There is definitely a metabolic acidosis. The serum albumin was 2 gram with this electrolytes. So if you check this, the pH is low, the carbon dioxide is low, the bicarbonate is low. So there is a metabolic acidosis. So if you evaluate the compensation here, the compensation should be around 23, but it is 34. So compensation is not full. That means body is retaining CO2. So the patient also has a coexisting respiratory acidosis here. So next, since there is a metabolic acidosis, I want to calculate the anion gap also. So anion gap is 13 here. So if you see this electrolyte report, the anion gap appears normal. That is sodium is 135 minus 112 plus 10, that is 122. So 135 minus 122 is 13. So anion gap appears normal. Like as I told you, anion gap is 10 to 14, 13. But if you see the serum albumin here, serum albumin is very low. So whenever there is a low albumin, we need to correct it for the low albumin. So if you want to correct anion gap adjustment, for the low albumin is equivalent to measured anion gap plus 2.5 times the difference in the albumin. So the actual anion gap comes here 18. So another equation I told you, for every 1 gram drop in anion serum albumin, the anion gap decreases by 4. So since the normal albumin is considered as 4, so it is deficient by 2. So 2 plus 2 into 4, 8. So you can add 13 to 8. That is around 21 it comes. So either of the way you can calculate. If you can remember this formula for the corrected albumin, you can remember this. If you can't remember the formula, just remember for every 1 gram per dl reduction in the albumin level, the anion gap appears to decrease by 4. So after calculating, this patient actually has a high anion gap. So if you calculate directly from this, only from electrolytes, it appears that it is a normal anion gap metabolic acidosis. Whereas if you correct it for low albumin, it is actually a high anion gap metabolic acidosis. And since the respiratory compensation is not adequate here, the patient is also have a respiratory acidosis. So the next example, or maybe last, I think here. So this is a 14-year-old girl with a bulimia who's brought to ER after being found unresponsive at home with a history of multiple pill ingestion. pH is 7.39. The PCO2 is low. The bicarbonate is low. So there is definitely a metabolic acidosis here. So if you want to see the compensation is appears to be 28. It should be 28, but it is PCO2 is less than 28. That means body is excreting or exhaling more PCO2 by hyperventilation. So there is an associated respiratory alkalosis here. So if you, since there is a metabolic acidosis, you have to calculate the anion gap. So anion gap is 38. It is pretty high. So this is definitely a high anion gap metabolic acidosis. So to know further, as I told you, in case of high anion gap metabolic acidosis, calculate the delta ratio. Here, delta ratio is coming more than 2.2. That means the patient is having a coexisting metabolic alkalosis. So this patient has a high anion gap metabolic acidosis. Along with that, patient has respiratory alkalosis and also metabolic alkalosis. So the 3 acid-base disorders which are coexisting in the same patient. So this is how you proceed the calculations of acid-base disorder questions. I think you need to visit through these slides for the multiple times to understand properly. Very much problem with the acid-base disorder is none of the single textbook gives all of the information. Some textbooks misses some things. Some textbooks does not mention the good concepts of anion gap, although it mentions the acid-base disorders very well. Some things mention anion gap very well, but the acid-base disorders are not mentioned very good. So pretty well, this much knowledge is very much sufficient even for a day-to-day calculation, patient purpose, and even for exam purpose. And if you go through this lecture repeated times till you understand the concepts, it will be very useful. Yeah. So I think I have made the difference for you guys in the discussion of acid-base imbalances here. So I hope you will get the answers right in the exams. So in the next class, I will try to cover the other acid-base imbalances, the left out 3, that is metabolic alkalosis, the respiratory acidosis, and alkalosis. Thank you.
Thank you so much, sir. It was such a comprehensive session for all of us. And acid-base disorders, as you rightly said, is not found in such a comprehensive way in any single textbook. And we as undergrads cannot refer to so many textbooks at the same time. So this session would certainly prove to be very useful for all of us. Once again, a big thanks to you, sir. And also thanks to all the participants for joining us in this discussion.
Thank you.